Hi, my name is Huei, and I'm currently one of the resident medical officers at Nepean Hospital, and my talk today will be on acute coronary syndromes. So just briefly about the lecture outline, I'm going to start off with a case first, and then talk about the background of ACS and also its management. So we'll just start off with the case. So the case is in regards to a Mr. John Smith. He's a 59-year-old male of Aboriginal and Torres Strait Islander origin, sent in by his GP to the emergency department due to crushing chest pain since the night before. And the GP called the ambulance because he still had ongoing chest pain and noted some ECG changes. And the handover we received by the ambulance officers was that he was given aspirin and GTN with good effect. So you go to see him as the JMO in ED, and he tells you that he still has some chest pain but seems to be easing right now, but he's still feeling slightly short of breath and also a bit nauseous, and he's currently diaphoretic as well. So I just wanted to stop for a second here and just wanted to let you guys think about what could be possibly causing this pain. I know this topic is on acute coronary syndromes, but I think because chest pain is such a common presentation, we should also think about other causes as well. So there are all these chest pain red flags that you should know about as well. This table is taken from the Heart Foundation website. So you can look at it as ischemic CVD causes, non-ischemic cardiovascular causes, and non-cardiovascular causes. But for me, it is also, I think it's useful to also think in a systems way, where for cardiac causes, it's obviously ACS and aortic dissection and pericarditis. You can also think of respiratory causes such as a PE or pneumothorax or a pneumonia. Gastrointestinal causes, you could be having reflux, peptic ulcer disease, or maybe biliary colic. And musculoskeletal causes, you could have costochondritis and cervical radiculopathy. And finally, there could also be psychogenic causes if you've got anxiety or panic disorders. So you get more of a history from this patient with his medical background. He's got alcoholic cardiomyopathy. He's currently got AICD implanted. He's got a history of type 2 diabetes, currently on insulin, and he's got associated peripheral neuropathy and diabetic nephropathy. He's also got a history of hypertension, hypercholesterolemia, fatty liver, hypothyroidism, and gout. So he's got a fairly long list of medications. He's already taking a statin, a Flozin for his diabetes, amitriptyline and pregabalin for probably neuropathy, and some medications for his cardiomyopathy, thyroxine, allopurinol for gout, some potassium replacement, and also insulin. So you go and note his obs, which were quite stable. On examination, he also appeared alert and orientated. However, just looks a bit unwell from the end of the bed. You notice that he's breathing quite fast, with also some increased work of breathing. He's got a bit of a bibasal crackle when you auscultate, but our heart sounds will dual with no murmur, but no elevated JVP. But he's got some bilateral pitting edema as well. And you do all these investigations for him. He had ECG, some blood sent off, and also a chest X-ray done. So before I go on and go ahead, I just want you guys to also have a look at ECG and see if there are any changes that you note as well. And also a quick look at the X-ray here. So in the ECG, there were some lateral T wave inversions in the lateral leads, in leads 5 to 6, but there were no ST elevations seen. And his chest X-ray shows some venous congestions with some small bilateral pleural infusions. And his bloods came back with a troponin of 726. So he's got a confirmed non-STEMI, and the ED team contacted cardiology and was recommended to be admitted and to start him on dual antiplatelet therapy and also therapeutic anticoagulation with Clexane, and was booked in for an angiogram the next day. So he had the angiogram done the next day, which shows that his left main coronary arteries were normal. However, in the left anterior descending coronary artery, the proximal first showed 90% of stenosis, and he had a PCI stent inserted. The left circumflex coronary artery showed some minor irregularities, and the right coronary had 20 to 30% stenosis. So just so that was a bit easier to interpret, I can just quickly show you a slide of just a quick revision on the blood supply to the heart. So there's two sort of main arteries. That's the left coronary and the right coronary artery. The left main coronary artery mainly supplies blood to the left side of the heart muscle, so the left ventricle and the left atrium. And the left main coronary divides into several branches. So the LAD, the left anterior descending artery, branches off the left coronary artery and supplies blood to the front and the left side of the heart. And then the circumflex artery branches off the left coronary artery and encircles the heart muscle. And then you have the right coronary artery here and supplies blood to the right ventricle, the right atrium, and obviously the SA and AV nodes as well, which regulate the heart rhythm. And then that further divides into smaller branches, just like the right posterior descending artery and the marginal artery that you can see here. So after the procedure, he was advised to continue with the dual antiplatelet therapy, to continue with the statin, and to continue with beta blocker. He was also commenced on an ACE inhibitor, and when it was appropriate, he was discharged home with follow-up with the cardiologist. So now that we've talked about the case, I also wanted to talk about the background of ACS. So what is ACS? It represents a range of clinical presentations from STEMI, non-ST elevation ACS, and also unstable angina, and they all share a common pathology causing a reduced blood flow to the heart, and it's usually a result of sort of unstable atheromatous plaques or endothelial disruption with associated transient or permanent thrombotic occlusion of the coronary vascular system, leading to myocardial ischemia and infarction. So like I said, it's a fairly common presentation, especially chest pain. 500,000 patients present in Australia each year with chest pain. And more than 80% of all these patients are investigated for acute coronary syndromes. And of the presentations of chest pain, 2 to 5% are usually STEMIs, 5 to 10% non-STEMIs, 5 to 10% are unstable anginas, 15 to 20% are usually other cardiac conditions, and majority of them would be non-cardiac diseases. This is why I mentioned before, it's also important to consider other red flags of chest pain when someone presents to the emergency department. So there are quite a lot of risk factors associated with acute coronary syndromes. So if you've already got an established cardiovascular disease, if you're a diabetic and you're older than 60 years old, if you've got microalbuminuria, if you've got moderate or severe CKD, prior diagnosis of familial hypercholesterolemia, hypertension with a blood pressure of 180 or more, and a diastolic blood pressure of 110 or more, and you've got a serum of total cholesterol more than 7.5, if you've got Aboriginal and Torres Strait Islander origin, and if you're male and also a smoker. So I just wanted to also talk about the initial clinical management. I think it's quite important for you guys to know. So the main assessments you would need to do is obviously an ECG and troponin, usually ideally within 10 minutes when they present to the department, and some sort of pharmacotherapy that you could give quickly, such as GTN spray and a 300 milligram aspirin if they've got no contraindications. And it's also good to give some analgesia. It's recommended you can give IV morphine, and also to start off with cardiac monitoring for the patient. And just wanted to quickly mention about oxygen supplementation. That's also recommended, but to be careful if their SpO2 is above 93%. If you give oxygen above that, it doesn't really sort of affect their morbidity or mortality. And should also be wary if that patient's got COPD, because they could be a CO2 retainer. So when you see the patient, obviously you should do the Socrates acronym to just ask them questions about their chest pain. And usually sometimes they could be quite diffuse pain and quite be difficult for them to localize where it is. Onset as well usually is sudden and when they're sort of exerting themselves. Most patients would describe it as squeezing pain or crushing pain. And the radiation is usually to the upper arms, throat, and jaws. And they could be nauseous, they could be vomiting and feeling short of breath. And the timing is usually variable, but it's usually longer than 30 minutes. And you also want to ask about exacerbating or relieving factors and how severe the pain is. And on examination, you obviously want to look at their obs if they're hemodynamically stable or not, because that obviously changes your management. And you want to do a cardiac and respiratory exam. If they've got any sort of evidence of hypoperfusion, if they're hypotensive, pale, clammy, or tachycardic with some impaired cognition. And if you also want to look for evidence of heart failure, if they've got an elevated JVP, if they've got basal crackles or new S3 gallop. And there are sort of features that are more suggestive of acute coronary syndrome that you should think in the back of your head when you're asking all these questions. Obviously, if they've got a previous history of acute coronary syndromes, if they've got vascular disease, if they've got the risk factors that I mentioned before, or if they've got any recent cocaine use or other sympathomimetic drugs, and if they've got those associated symptoms mentioned before, like shortness of breath, nausea, indigestion, vomiting, diaphoresis, dizziness, and fatigue. The Heart Foundation website also has a table of what risk would be more sort of suggestive of a cardiac cause of chest pain. If they've got obviously an elevated troponin level, if they've got ischemic ECG changes, if they've got hemodynamic compromise, sustained VT, syncope, known left ventricular systolic dysfunction, or prior AMI, and if there are also sort of traits to suggest they're a lower risk for a cardiac cause of chest pain. So there are also risk stratification tools. For this, I'm sure you've probably heard the TIMI score. That's probably the most commonly known one. But there's also the GRACE, the CRUSADE, and ACTION. I'm just going to briefly talk about the TIMI and the GRACE score. So you can find the score also on the NTCalc website to sort of help you calculate this a bit quicker. So all of these, if you add up, you can just, that contributes to 1 point to the score. So if they're above 65 years old, if they've got at least 3 risk factors for CVD, if they've got coronary stenosis of 50%, if they've got some ST segment deviation on the ECG, if they've got previous anginal episodes in the prior 24 hours, if they've got elevated troponins, and if they've had use of aspirin in the prior 7 days. So the point of this score is that if it's a high score, it indicates an increased all-cause mortality or also a new/recurrent MI, or severe recurrent ischemia requiring revascularization at 14 days. The gray score is a bit more complicated. Like I say, you can also use this on MD-Calc to give you a score. So the point of the score is to just estimate the admission to 6-month mortality for patients with acute coronary syndrome. And for the Heart Foundation website, they also have sort of their own table to classify a patient whether if they're high risk or not. And obviously, if there's hemodynamic instability, life-threatening arrhythmias, or ongoing ischemia, that puts a patient at very high risk. And they also include the GRACE score as well into their table. So this is the suspected ACS management pathway that I took from our hospital protocol. So depending on where you guys end up, this will probably vary depending on your area that you work in. So this sort of summarizes everything what I mentioned quite briefly. So it tells you what to do initially when there's someone with a history that's suspicious of sort of acute coronary syndrome, and then what to do if there are ST changes, and if there are features that show ST elevation, then there is a separate STEMI pathway that I'll show in a second. And if there are other high-risk features, then you should get a senior MO review and to possibly talk to cardiology on call. And if not, then you should consider other alternative diagnoses. But they also recommend to repeat TROPS and ECG at 2 hours. Then if they've got a low risk, then it tells you they could be discharged and to follow up with a GP. So this is the STEMI pathway. So if they've got symptoms suggestive of a MI with ST elevation in 2 contiguous leads, and you have to consider if there are any contraindications to treatment, and then you would contact cardiology, and then they usually provide further advice on what to do after. So for STEMI, usually the recommended treatment is reperfusion therapy with PCI usually, and that's more recommended if you've got a door-to-needle time of 19 minutes. The other treatment option is fibrinolysis. However, PCI is still preferred because they still have improved mortality compared to fibrinolysis, unless contraindicated, obviously. And these are the sort of reasons why you would use fibrinolysis over PCI. This is especially if there are unacceptable delays in the cath lab for primary PCI, or factors that will impede sort of successful performance of a PCI. And there are also contraindications to fibrinolysis that you should know about. So if they've got significant hypertension at 180 over 110, if they've got recent surgery or trauma, if they've got prior bleeding, GI bleeds in past 2 to 4 weeks, if they've got a stroke within 12 months, a prior intracranial hemorrhage at any time, or if they've got sort of bleeding diathesis or they're currently anticoagulated. So with non-STEMI, management is a bit different. This is why risk stratification is so important, because that sort of changes management for some patients. You would consider reperfusion strategies as well with PCI or CABG, and when you would do that is dependent on how unstable the patient is. And if they've got a higher risk, you could use dual antiplatelet with parenteral anticoagulation with a beta blocker, which is what the patient on our case had. If they've got intermediate risk, you can just start them possibly on antiplatelet therapy. And if you're low risk, you can just consider that treatment. However, fibrinolysis therapy in STEMI is not recommended. And in terms of long-term therapy, it's also important to know what they should go home with. And um, if they've got a PCI put in, usually do antiplatelets recommended for at least 12 months, and they should also continue with aspirin after. They should be started on a statin if they haven't been started on it already, and beta blockers as well, and also an ACE or an ARB within 24 to 48 hours of AMI in patients with left ventricular failure or dysfunction. So just wanted to briefly talk about unstable angina. Um, you should consider it in patients with symptoms that suggest an ACS, but they don't have any elevated troponins with or without any ECG changes. A small proportion of these patients will have some resolved symptoms as well after they present, and they still don't have any ECG changes or just still normal troponin level, but it is suggestive of underlying disease. And if you think they've got a intermediate to high risk, then they should be investigated further, whether as an inpatient or outpatient. And those who have been discharged, they should be discharged with an appropriate management plan. They should follow up with their GP for sort of subsequent testing, such as a exercise stress test or an echo. And you should advise these patients when they should represent if needed, and to consider them to go home with some GTN spray and also aspirin. And last but not least, don't forget to advise on risk factors. You want them to control their diet, exercise, to stop smoking, have proper glycemic control, manage their hypertension, and also stress management. Sorry, I meant to say this was for modification. And these are my references. Thank you.